Guys, welcome to Clinical Unfiltered. So, today, give me your hearts, minds, teeth so that we can get unfiltered with Dr. Nathan Estrin, who's been on an episode before with us. And today, we're going to be talking about lasers, dental lasers. And I know this podcast has actually done episodes on lasers. And I think we'll do many more to come because I do think it's a very cool technology that's in our field. And the more we dive in about it, the more pearls we can extract from it. Dr. Ashton, what is your experience with lasers?
I worked with Dr. Georgios Romanos. I don't know if you're familiar with him. He was my main mentor at Stony Brook when I was a resident. He's a laser guru. He's a guru of many things because he's an oral surgeon, prosthodontist, and periodontist. So he's a specialist. Really research focus. I know.
Does he live in the school?
Pretty much. He's there
Yeah,
late
yeah,
hours.
yeah.
I've been with him late hours many times, but he's a
That
genius.
is an academic. Awesome. Okay. So that guy loves lasers. The guy who's learned everything in dentistry loves lasers. Yeah.
And he had every wavelength at his arsenal at the school. So I got to play around with a lot of different lasers. That's what my master's thesis was in laser wavelengths, um, specifically histology comparison between these laser wavelengths. So that's where I got my start to lasers. And of course, a lot of periodontists use lasers. I can't imagine not using lasers.
So you've been lasering since you got out in school and since you got out of school to this day.
Cool, yeah.
I got to ask you then. I mean, you probably have multiple lasers.
Uh, I'm at a perio office that uses Lanap, Millennium Laser, and I'm at a group practice where we use the Photona that has both ND-YAG and erbium-YAG lasers. So,
Gotcha.
so that's what I have now. I would love to get a CO2 laser. Unfortunately, lasers are expensive,
Oh
so
yeah.
it's probably going to be way later in my career when I've got all the different lasers that I want to use.
Oh yeah. I will tell you that's probably like I haven't never talked to anyone who's been against. I mean, I take that back. There have been people who are against lasers, and I too used to be against lasers. At least, in our periodontal field, the use of a periolase, I used to be against it because I'll tell you honestly, the entry point to the cost was so much that I think I did a backwards flip in my mind to say, "Nah, you don't need lasers." Because it was so expensive, but I wasn't honest with myself. So anyone listening right now, if you think lasers are crappy and don't work, I want you to step back and think, are you saying that because it's too expensive to get in? Be honest with yourselves. Reflect right now.
It's definitely
When
expensive.
you got out,
Lasers are
did you
cheap.
never have to buy any of your lasers when you came out? They were already there.
They were already there. So,
Oh, lucky
but
you.
it but, you could get a diode laser that's pretty inexpensive, and to me, a diode laser works very similar to an ND-YAG, and
Okay.
anyone that tells me, otherwise,
Interesting.
I will disagree with them there.
Okay. Well,
And
let's
Dr.
start.
Romanos would disagree with them, yeah.
Let's start there because um, uh, 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 I want to know why I overspent for a laser.
ND-YAG's a great laser, and of course, there's other benefits to being laser trained with a big company and get that support, et cetera. But, diode is similar, and really what it comes down to is, a laser isn't a laser isn't a laser, that each laser type is different, and the type of response you get to the tissue is going to depend on the wavelength. So it's a little complicated, but the best way that I can explain it is, let's pretend, I'm an asshole and I'm going to insult multiple people. Okay. I'm one wavelength. My insults are the same. How each person responds to it is different. Okay. So if you're hard tissue, soft tissue, water, et cetera, you're going to respond differently to the wavelength.
Okay, so let's go down the wavelength rabbit hole. That seems to separate a lot of the lasers and their uses.
You have laser tissue interactions, which are either transmission, where the laser goes directly through the targeted tissue, absorption, where the target tissue is absorbed. You have scattering, where the laser targets the tissue and branches off and scatters in different directions. And you have reflection, where you point a laser and it comes right back at you on the tissue. So, what you want, what the desired interaction is absorption. you want absorption by the laser. Okay, so each tissue has different absorption coefficients. Okay, each laser is going to interact differently with different types of tissue. And so when I hear someone say, "Oh, I used a laser and it didn't work," it's not enough. I need to know what type of laser, because each laser has its different advantages and disadvantages. And really, it's getting complicated. All you need to do is just Google absorption spectrum of laser wavelengths, or Google absorption coefficient diagram, and you'll see the different absorption coefficients of different laser wavelengths and tissues.
Yeah. So I mean, I remember because I have I have the Periolase. I remember going through the course and they kind of had a diagram showing like what the absorption of the different tissues were. And kind of showing how like the ND-YAG was specifically in a certain range that happened to match up with periodontal based issues.
Right. So that's really it. So for example, erbium YAG is highly absorbed by hydroxyapatite and water, and you can use it on hard tissue, where ND-YAG is absorbed by hemoglobin and melanin is used more for soft tissue. And that's why you coagulate more when you use an ND-YAG versus an erbium YAG, because of that absorption of hemoglobin.
Right. So if you wanted to get into tissue and like hard tissue, erbium YAG. What are some erbium YAG lasers that are popular in the market?
Fotona is the one that I use. That's probably the most popular because it's got both wavelengths.
I didn't realize it's an erbium and an ND-YAG laser.
It's an erbium and an ND-YAG laser. And
Like you just flip a switch and it goes from erbium to ND.
it's got different
Oh, like hoses and not.
yeah,
Ah, gotcha.
but hoses.
And I don't think people realize that the erbium and ND, those are like elements.
Yeah, so what determines the wavelength is the active medium in the laser device. Okay, so we'll take a step back and get back to the basics of lasers. You have an active medium. Okay, and that's what the laser name is. So if it's an ND-YAG, it's a neodymium crystal. That's the active medium. Or CO2, the active medium is CO2. You have an external power source. That's why you plug your laser into the wall, and that stimulates the active medium into an excited state. So if you think back to chemistry, you have an atom, an electron jumps out of an outer shell and comes back, when they're stimulated, and that produces light. And I probably butchered that explanation, but I think it's
No, I got you. So the ND-YAG is what, like the ND stands for, you said kind of like is it an element or a crystal? It's a crystal.
yeah.
It's a crystal. So it's actual freaking crystal inside you crack open the laser, you find that medium, it's a crystal in there.
It's a crystal in there.
Okay, gotcha. So you got a power source. The power source powers what? A light to excite it? How is it exciting it? Is it like with like an electrode
I don't know.
zapping?
Now
Yeah,
getting into the specifics. I'm not.
gotcha. Okay, you don't know it.
No,
So you haven't cracked open your $100,000 laser.
no.
No. Okay. Good. From what I remember, it sounded like there was some form of stimulation of the crystal, and then the light that comes off that, or whatever wavelength of energy comes off that, is being funneled through it, at least in the ND-YAG, through like a fiber optic cable. Correct? And then and then it comes through that fiber optic cable. And if I'm correct or wrong, the wavelength of light is not on the visible spectrum that's coming out of there.
Out of the ND-YAG?
Yeah,
Yeah, it's just out of the visible spectrum.
just out of the visible spectrum. So I feel like people when I turn on the ND-YAG laser, it's got like a red tractor beam, and everyone assumes that's the actual laser. And I'm like, no, that's just like me being able to guide where the light's, coming out of, making sure that the light is traveling through the fiber optic in a clean way. Like if I'm not getting the red light, the next light that I need, like the wavelength that I'm trying to actually send through the wire, isn't coming through if the red light isn't coming through. The red light isn't actually what I'm looking for. It's the invisible light that I'm about to press on this pedal and shoot out. And I know and I think most lasers have this, but the ND-YAG laser that I've used has like different pulse settings. Like it when the light's coming through, you can pulse it, and the duration of the pulse and how frequently it's pulsing. So you can hear it's like da 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 da, or like da 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 when you press on the pedal, affects how you're going to affect the tissue, or how much energy you're putting into the tissue. Like how much, I'm assuming how much you're going to heat it up.
So all laser is heat transfer. So when you have a pulse, you allow for thermal relaxation. So for the tissues to cool off. It's like putting your hand on a stove for a second. You're not going to burn your hand. But if you put your hand on a stove and hold it there, you're going to burn your hand.
Gotcha. And so like when I use the laser, sometimes I do want to burn. Like I kind of want to maybe ablate some tissue. Then I feel like the pulse is longer. It's like, I am holding instead of hearing dun 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 dun, it's like duh.
And I might be wrong for this, like I did a lot of laser research in residency. Since then, it's been all PRF. But for me, I'm the type of clinician I don't pay as much attention in the settings as I probably should, and rely on time. You can observe the tissue, and time is going to affect the outcomes more than anything else.
Really, I mean, you take the courses, you learn all the basics. The ND-YAG has presets, and I love a laser with presets because they're pretty much setting the duration of the pulse and how long the pulse stays for, um, based off presets. And it's like, okay, I'm gonna do a frenectomy. It's got a frenectomy button. I'm gonna do, periodont. I'm gonna do Lanap. It's got Lanap buttons.
And thank God for those presets.
Oh yeah, thank God. Exactly. You said the diode. You meant you had thrown this word out there. You said that the diode could sometimes do what we're needing to do out of the ND-YAG. What did you mean by that? And how does the diode work?
We got into absorption coefficient. It's a very similar laser in that you use a fiber optic to deliver, but they're actually very close on the spectrum. Diode, is anywhere from 445 to 980. Okay, 980 is a very popular diode wavelength. ND-YAG is 1064. So they're very close in wavelength. So they have very similar tissue interactions. And I feel like a lot of people say that diode wavelengths don't cause any photobiomodulation. Okay. And to explain what that is, when you heat up a tissue, what makes a laser different than an electrosurge? They both are going to burn the tissue. You're going to see the tissue burn, but the laser will stimulate the surrounding tissues that you can't visually observe and excite those tissues. And that's biostimulation. Okay, so a popular device, ATP38, that's used in facial aesthetics. Okay, it's called ATP38 because you get one extra ATP from the Krebs cycle. So instead of ATP37, it's ATP38. That's why I called it that. So if that
Gotcha.
helps you remember what photobiomodulation is.
Yes, because I remember the Krebs cycle.
Well, if you remember why it's 38 and not 37.
Gotcha. Yeah. Now I might actually remember
But
the Krebs cycle.
everybody should remember the Krebs cycle.
Sure, Nathan.
Yeah.
Sure.
I don't remember the Krebs.
Mr. PRF painting over here.
Yeah, right.
Because of that that close distance of wavelength from the diode, it's not that far of a jump to go from the ND-YAG to the diode.
It's not that far of a jump. Yeah, so and you've got a device like the ATP38. Why I brought it up is because that is a device that solely does photobiostimulation. You're not burning any tissue with that. It's just there to excite the tissues. So, and they're all diode wavelengths, all of them. They're all diode wavelengths. So if anyone tells me diode doesn't cause biostimulation, here's a whole company dedicated to diode wavelengths and doing biostimulation. All lasers have some sort of
I'd be
biostimulation.
super interested. Have they? I mean, has anyone ran a study on doing kind of like periodontal based therapy from Lanap versus or from an ND-YAG?
I don't think anyone's got the balls to do that type of stuff.
Oh wow, yeah.
I know. I know. I
Yeah. I mean, I would assume a diode laser company would want to give it a whirl
There you
just to
go.
see, yeah. Because the entry of a diode is it's easier than an ND-YAG or an erbium-YAG laser.
I'm sure with the ND-YAG and the bigger machine, you can change the pulse durations and you can pay more attention to the settings than I do and get some type of, better response. So, I'm sure a lot more research has been put into, the ND-YAG device and the Lanap device. But if we're talking, just basic laser physics, the diode wavelength, ND-YAG wavelength are very similar.
Well, you're right, because I mean, diode is notoriously for soft tissue based procedures. At least in dentistry. I feel like if you're getting a diode so you can like do frenectomies and do things like that. So it's soft tissue absorbed, which is what kind of the next step up in that wavelength the ND-YAG is. But then the erbium YAG is different. The erbium YAG does enter a different realm where you're now able to cut hard tissue, correct? Because you're absorbing into now the light's getting absorbed. That wavelength gets absorbed into bone, correct?
Bone and water. Yeah.
And water. Okay. Gotcha. The CO2 compared to that erbium YAG. What is the CO2?
Still to 10,600 nanometer wavelengths. And if you look at the curve, it is similar. Yeah, that's probably the laser that I have the least experience with since I haven't had one and
The CO2 lasers I run into much less frequently, but I remember there was some directionality where it could help
light
more with
scalpel
light
was a
scalpel. Okay,
popular one.
gotcha. I remember that running into the category of using it for periimplantitis, potentially, is where CO2 lasers might have a better use over, for example, an ND-YAG laser. Because an ND-YAG laser, in theory, you put that wavelength, like I said, it's getting absorbed by more pigmented based tissue. Your implants are highly, highly got a color to it. So my experience is when it touches an implant surface, it pops to a point where it's not healthy for the implant.
Yeah, no, you can overheat the implant, and a lot of studies have shown that Nd:YAG can cause melting, cracking, and I believe the LAPIT protocol, the picture that they use, they have the Nd:YAG laser pointing away from the implant surface.
Right. Yeah. So actually, my protocol. So again, I have the ND-YAG. When I'm using it for round implants, if I can't remove the implant crown, I'm less prone to actually use it because I'm more likely hitting the implant surface directly. So if I can remove the implant crown, then it's easy for me to get my instrument parallel to the implant. So the fiber isn't like pointing at the metal. I can point it away.
What have been your results with Nd:YAG around implants?
Really good if I can get it off. If I can get it off, I can be really minimally invasive and I'm cleaning the heck out of it. I'm not actually introducing a lot of Paradex or anything like that. I'm pretty much just utilizing the laser to clean around it. And I'm disrupting the tissues as least as possible. I'm kind of focusing on that kind of disruption of the biofilm without, any kind of major surgery. It's a very minimally invasive surgery if I can get the crown off. If I can't, I've done it. I get a lot of tissue dieback in the process. And I think it's because, I mean, then nothing's going to break. So you end up with these weird soft tissue defects around the implant where stuff starts to impact underneath. And I feel like we've still lost the implant in those scenarios. I will tell you in general, I mean, this is just another conversation, but I remove more often than I treat periimplantitis.
Me too.
But if it's screw retained, I actually am open. Then I open up the door more frequently. I'm like, okay, we got a chance. We can remove the implant, clean around the outside with a laser. And then if that doesn't work, if we're going to get aggressive, let's just remove the implant. Like if we're not going to get aggressive, we can try with the laser. And actually, that's probably where I find the best use of my laser is that I get to introduce. Well, I do a lot of I do a lot of like advanced periodontal therapy. It's easier to get a patient to do extensive periodontal therapy with a laser than it is to tell them you're going to do surgery. You tell them you're about to like cut and start to open up the gum tissue. The treatment acceptance rate drops versus telling them you're going to do a laser to do it. And I mean, I've seen it. It's just like I look at my schedule before I had the laser, I look at my schedule after the laser. There's just a lot more advanced periodontal therapy on my schedule since I've had the laser.
And patients come in and ask for it. I'm sure you experience that too.
You know what? I'm
Oh,
shocked. I don't get it. I mean, as a periodontal referral office, I don't get a lot of that asking about. But when you bring it up, they are enticed by the technology. They are. You bring up lasers, they're like, okay.
how have
You
your results been in like really severe cases?
honestly,
Do the whole Lanac protocol, occlusal adjustment, and
yeah, they've been the best in severe and minimal cases. It's the middle zone that's a little bit harder to manage. But the severe cases, a lot of the times, the bone loss is so generalized that there's not a lot of defects that are graftable and regenerable in there that just by the net fact of getting in there and cleaning everything. And a lot of times those I will do almost like a full mouth disinfection kind of protocol where I'm like, all right, we're going to sedate you and go through the whole mouth and clean everything. They look great. it's about their maintenance afterwards, that's big, that's important. But the thing is, even with the laser, now that they've gone through it, to tell them, "Hey, there's another spot that's ailing," maybe like 2 years, 3 years down the road, it's gonna be much easier to tell them to do the laser gum therapy again than to tell them, "Let's do surgery again," you know?
especially when they have a good experience.
Yeah, exactly. Yeah. So I like I don't mind doing a touch-up procedure because it's quick and it's easy to do that.
Oh, it's way faster with the
But the thing is, I do, and this is why when you bring in the diode, I do up my energy to ablate more tissue. So I kind of trough more tissue than I think the traditional LANAP protocol that they came up with is intended to do. So, because I still believe in removing calculus, so I still get in there and I'll use my laser to remove it and get access, and then clean off with my other instruments, my piezo to clean off calculus. I still like to remove etiology if I can. Photona laser with the erbium YAG, have you used it to do things like crown lengthening?
Yeah, I've used it, and I'll say it takes longer and we just said it's faster with a laser. It's faster to do osteosurgery with a laser than it gives.
Yes.
But when
Yeah.
it comes to crown lengthening, aesthetic crown lengthening, I've gone back to flapping just for speed's sake.
Oh, yeah. Well, you have to be a little bit more exacting there too.
With a laser, because you're going blind, yeah, you do have to.
Right, exactly. I think that's the thing is I've seen people promote that technique and I'm like, how could you know where the bone ended up, you know?
For case acceptance of a patient's absolutely not surgery, then I can see the appeal of doing it. But otherwise, you know, we all got trained and doing, flat crown lengthening. So it's just faster.
I've talked to people who do it more frequently with the laser. And we ran like a pilot study when I was in residency of using like for crown lengthening purposes. There was a little bit more relapse with using the erbium YAG, using a laser to do the crown lengthening. And then our thought process was maybe we're not getting enough bone removal when we're doing it because we are a little bit more blind. And that is the nature of a laser, is that you are almost trusting the technology to do a little bit more of the heavy lifting than when you're doing surgery, you have to get in there and do all the work yourself. Whereas a laser is, you're not magic, but you're using the magic of the laser to do a lot of the heavy lifting for you. And so I feel like with aesthetic crown lengthening and even functional crown lengthening, you're trying to get some exacting numbers of bone removal, and you just can't get it sometimes with using a laser to cut bone per se. But sometimes there's just a little bit that's needed. I've seen those cases where it's like barely minimal amount of bone of like aesthetic. Aesthetic one is a little bit easier because you're just removing like little thin facial plates sometimes. And so that one I feel like works better than like a functional crown lengthening, where you got to remove bone all the way around the tooth. Um, I don't even know how you approximate how much bone you've removed in between the teeth. Um, that could be very difficult and a little bit unpredictable.
Yeah, I've always thought they should make, I'm sure you've seen those measurement tools, for aesthetic crown lengthening or
Oh, yeah.
I've
Yeah.
always thought they should make an erbium YAG tip with that.
Oh, wow, just the tip itself is sure.
Yeah, I
That would
don't
be
think
great,
I have
yeah.
it in me to
Yeah,
do that project, but I hope someone out there
that would be
has a good
awesome.
idea.
The erbium YAG, is it still a fiber optic cable that runs through the erbium?
No, it's not a fiber optic cable, it's a glass fiber tip at the base. I believe it's a series of mirrors that directs the laser light, and then you have different tips that you can select for different shapes. So you can have, a chisel, wide diameter, conical. They've got tips that are pointed, X sweeps tips that directs the laser light laterally. So they've got a lot of different
Do you feel like the handle is harder to use on that versus like an ND-YAG or a diode laser?
It's definitely not as flexible, but, in my practice, we use the ND-YAG all the way to the end, so I end up with, like, a very short cord. I think that's hard to.
Gotcha. Is it a flex to do that? Like,
It's
"Oh, look."
I don't know if it's a flex or, if my office just hasn't ordered a
Try
new.
to save money.
Yeah,
Yeah.
yeah, exactly.
Oh, we use every ounce of fiber too. Like if an ounce gets wasted, it's like, oh man.
Yeah,
Because I will tell you, if you're getting a laser, the reusable costs of the fiber is something you definitely have to manage and think about. Because like initial cost of laser, then the reusable part really is. I mean, if the Nd:YAG and the diode is the fibers, and they run out, you have to like cleave them every other time you're using them. And so, um, you run out of it. It shortens up like a, you know, like a candle thread melting away. And so you have to replace those, and those can be expensive. They're not pretty cheap. So I'm very aware of those as well.
We try to save what we can.
The lasers too, a lot of times, like the ND-YAG laser I know that I use, I have a warranty that I do reuse every year because I at this point, it's such a mainstay of my practice on the way I treat periodontal disease that if it's out of the office, we almost have to like reschedule patients because it's hard to tell my patients we are now then doing surgical rather than the laser. So they would rather reschedule and we're down until we get the laser back. And so having a warranty is like a faster way to be able to fix the laser and get it back into the office. The photonal laser, do you feel like it ever goes down on you or do you send it in for maintenance every year?
There are more maintenance checks, it just depends on the rep that you work with. But I
Okay.
feel like I have maintenance checks with the Lanap machine too, where
Yeah. Oh, I do manually. I
yeah,
send mine in annually. Like I line up a vacation and I send them in and then I'll go, then I don't have to worry about rescheduling. I'm like, hey, we're not in town. Perfect. Send it off. And then it comes back and we're patients are ready to roll again. And if I do that, then I don't really run into like random issues of my laser and have to deal with that. Cause that is, I mean, when you introduce any technology into an office, you have to be like, have that contingency for if it's going down. Especially when it's very critical to your workflow. I'm assuming you're using it every day because you use it for advanced PRF techniques too, correct?
yeah, I'll do the laser first and then add PRF too. But even when I flap, I'll use a laser. I still think it's great to degranulate if you have a defect.
For sure. For surgical therapy, it's always in my room. Even for sockets. For sockets, I take out a tooth, I run the laser in the socket to clean it up. It's a part of my, and I will tell you, it was weird. The first year I got my laser, my ND-YAG laser was the first year I had next to zero complications. And I was like, maybe I'm chalking this up to pure freaking or luck. Um, or it's got to be the laser. I thought the coincidence of the laser was like I was like, man, this is insane. It's like literally I'm tracking it to that time point, and I had like 1 year then I had some complications. I'm like, all right, the curse has been broken. And now I have issues. But in general, I do feel like I now because of that, I'm almost superstitious. Like if I do an extraction socket graft and I didn't degranulate with the laser, I worry just a pinch more. Because I do believe it does a good job of disinfecting.
Mm.
And so yeah, even when I have even
Advanced
when I have
biostimulation,
right.
you
Do
know.
you do you so have you done it for any specific biostimulation like issues?
I used to have an ATP 38 machine. We had one in the office for facial aesthetics, and I would put patients in immediately postoperatively. And our machine did run into some issues, probably just being moved room to room. You know, it ended up not working as well, and we just never replaced it. So
Gotcha. See, that's what I'm
that's
saying. It's like
something I would love to get another machine. I think it's great to do for your post-op appointments, and patients love it whether it works or not. Uh, patients love it. They feel like they're getting treatment instead of just a very quick 5-second look that there's no infection, everything looks good.
Nathan, thank you for taking us to the periodontal office of the future. See, I mean, between our episodes on the PRF and the laser, I mean, you can imagine the patient's experience coming into Dr. Estrin's office being like, well, okay, this guy's lasering blood concentrate materials. This is the future being applied now. So guys, again, thank you for being getting unfiltered with us, with me and Dr. Nathan Estrin as we talk about our experiences with lasers. And of course, we do not get paid for this. You're not getting paid for this, Dr. Estrin. Sorry, buddy. So you could not help pay off your beautiful PRF painting and against the
Yeah.
wall.
Right.
Please share, follow, like, comment so that we can continue doing what we love, which is sharing unfiltered clinical dentistry with you guys. Thank you so much, Dr. Nathan Estrin.
Thank
Take
you.
care.
Thanks for having me.